Thank you for this kind introduction. I want to thank European Heart Rhythm Society and the committee for this opportunity. I'm going to talk about yet another complex case. In this case-based discussion, I want to present a case which highlights some of the characteristics, electrocardiographic and electrophysiological findings seen during mapping of these papillary muscle PVCs and challenges involved in the catheter ablation of these PVCs. I have no disclosures which are relevant. Catheter ablation of papillary premature ventricular contraction, in addition to causing a debilitating symptoms, can cause LV dysfunction. Multiple single-center studies have shown catheter ablation is quite effective in curing this. However, ablation of papillary muscles seems to remain challenging. This slide shows the pooled data from 8 centers, where we see the acute success of the papillary muscle, which is seen in this green bar, seems to be acceptable. However, the long-term outcome data remains sobering and often requires use of antiarrhythmic medication for any reasonable outcome. More importantly, the procedural duration, the fluoroscopy time, and the radiofrequency catheter ablation time, all of them remains significantly greater for papillary muscle VTs when you compare to other areas, highlighting the challenges involved in the management and ablation of these arrhythmias. This is perhaps not surprising when we look at the anatomy of the papillary muscle. Papillary muscles of the heart are complex intracavitary structure. Their shape and size are highly variable, and so is the subendocardial vasculature and the Purkinje conduction system. Anatomically speaking, the papillary muscles of the heart are the thickest structures in the heart and comprise of complex of myocardial strands with the separation between them at the basal and the apical side. This likely results into the anisotropic conduction. These anatomical features have a considerable influence on the properties of the arrhythmia we see originating from these structures and the challenges we face during ablation. I'm going to now move into my case. Here we have a 65-year-old male who had a bypass surgery in 2004. In 2009, presented with shortness of breath to his general physician and was found to have cardiomyopathy with an ejection fraction of 27%. At that stage, patient ended up having a defibrillator implanted. Was managed medically until 2011 when he had palpitations with shortness of breath. A Holter monitor was done, which shows a PVC burden of around 28% with runs of non-sustained VTs, which was seen on the defibrillator. These was patient's medication, and unfortunately, patient did used to get rash from imidazole, and that remained out of question. This was the PVC which was seen at the time. As we can see here, this patient has a right bundle branch morphology with a V5 transition. We have a superiorly directed PVC with positive negative in lead 1, suggestive of coming from left ventricle, somewhere near the inferior area, most likely near the posteromedial papillary muscle region. Now, this patient presented to peripheral hospital during that time, and that time the decision was made to take the patient to the lab. They took the patient to the lab, and unfortunately, which is not a very infrequent clinical scenario, there were very few PVCs seen by the time they took the patient to the lab before the groin access though. We can see here there were different flavors from right bundle superior axis to right bundle inferior axis PVCs were seen. Most predominant remained the posteromedial papillary muscle. However, the anterolateral pleomorphic PVCs were also seen. Now this brings to my, this patient was then, the decision was that they wanted to proceed with catheter ablation. The activation map was performed for a number of limited PVCs which were seen. And the earliest activation was found, in fact, near the posteromedial papillary muscle. This was the PACE map, and the decision was made based on the PACE map to do the catheter ablation. Not surprisingly, patient continued to have frequent PVC next day. As the patient continued was managed medically until 2019, when this patient came to our hospital with increasing shortness of breath and palpitation. At that stage, the echocardiogram shows the LV cardiomyopathy has progressed and continued to have mild mitral regurgitation now because of the LV dilatation. Had a Holter monitor and showed a PVC burden of 32% and kept having non-sustained runs of VT. As patient was allergic to amiodarone, ended up being on sotalol. And these were other heart failure medication the patient was on at that stage. These were the 12-lead ECG different flavors we managed to find either from the 12-lead Holters or from different emergency department presentation. And I'd like you to take you through this. As we can see here, the PVC which was seen had a right bundle morphology. However, they were occasionally significantly greater superiorly directed, suggestive of a variable exit. We also saw multiple different flavors. Mostly, if you concentrate on the lead one, we saw somewhere where there was positive, negative, with more predominantly positive rhythm, and sometimes significantly negative rhythm, all suggestive that there was significant variation in the exit of these PVCs. Additionally, what we saw here was sometimes these PVC were coupled. That means we had a right bundle morphology with a V5 transition with a superior axis occasionally coupled with the inferior axis. So these were the different flavors of PVC seen, almost suggesting we are up for a challenge. So my first question then comes, what will be your approach? Will you change the antiarrhythmic medication and start patient on flecainide? Patient was taking sotalol and, mind you, has amiodarone allergy. Will you do a cardiac MRI, and if there is no scar, then start flecainide? Upgrade them to a CRT, or do cardiac MRI and plan for a catheter ablation using intracardiac echo? So I'll ask for the opinion for the poll. Mind you, not an uncommon situation where patients may prefer sometime not to go for a ablation. However, we are talking about where the patient is happy, and we are looking into, in a pleomorphic condition, whether we should be giving them antiarrhythmic or should we proceed with a catheter ablation.
94%.
So you'll be very pleased to know, Rajiv, I think that everybody wants to take your option D.
That's fantastic. I guess we have ablationists in the group. Huh?
I think so.
Move on with the case, and we'll hopefully have the answer. The use of multi-imaging modalities such as cardiac MRI and real-time imaging data from intracardiac echo is helpful to identify the different size, shape, and site of origin of PVC, and can enable us to better understand the underlying substrate. As you can see here, we can appreciate the scar, and sometimes this can guide us to try and change our strategy for the catheter ablation and also the approaches. So I'm glad that everyone agreed that we should do a cardiac MRI and proceed with catheter ablation based on the imaging technique and the things available. As we discussed, the patient continued to have PVC, and this was the most frequent PVC we saw. This will bring to the next and the final question I have for our audience. Now we see this PVC. So for this patient, when it comes to the lab, what will be the best approach for the better outcome? Should you create an ice-guarded geometry, use a 3D map? Will you use a contact force ablation catheter? During mapping, will you use activation map or pace map, or all of the above? So I'll again open this for the audience for the poll. I guess these are our different technologies we like to use, and these are the different activation and mapping methods which are available. And it'll be interesting to know how the audience like and what are the different approaches that seem important in mapping of these different PVCs. I guess we'll wait for the audience to tell us what they think we should do for this case.
They're telling you that they would like to use all of the above, 81%.
Fantastic.
Like to use them all.
That's great. All of the above and a little bit more than that. We all have already discussed the importance of multi-imaging modalities. However, there are several isolated factors which have been identified in previous series which predict the outcome. These include the electrocardiographic parameters such as pleomorphic PVC. We know, unfortunately, presence of pleomorphic PVC suggests a poor outcome. Electrophysiological properties such as activation map, pace map can be utilized and they predict success. A bipolar R wave, presence of prepotential, and acute morphology. Similarly, the imaging data such as papillary muscle size and lesion volume have also been suggested as the outcome. So we proceeded with the case. Considering the PVC was frequent, we then decided to take the patient to the lab, had access, and as our normal workflow, we create a carto-guarded and ice-guarded carto sound map. We pay attention to the anatomical structure, and we also sometimes do CT scan to understand that. Then using a catheter with a force and directional sensing, we diligently map and do an activation map on these PVC. We use intracardiac echo so that we can appreciate the anatomy, which we did in this case. And we found an early pre-potential, which was 30 millisecond pre. This was on the posteromedial papillary muscle. So this was the site where we found the early activation. The earliest activation, as I said, was 30 millisecond pre. This was at the apex of the papillary muscle around this region. We continued to do the activation map. And what we found as we moved from the tip towards the body and the base of the papillary muscle, we found this far field signal, which was way too early. The decision at that stage was which one is the most appropriate site for us to ablate. At that stage, because the sharpest signal was around the apical area, the decision was made that that will be the area of interest. We did the pace map, and the peso match was around 94%. We then decided that we'll ablate in that region. Ablation was performed with reduction in the frequency of this PVC. However, unfortunately, we continued to see the PVC. However, there was slight variation in the morphology, suggesting that there were now a separate preferential exit of that PVC. So the one question which comes then, what should we do? We moved towards the body. We found an earlier spot, which was around 43 millisecond pre, and this was at the site B. The signals were a little more far-field initially, but with more mapping around that area, we found this area and an ablation lesion was performed with complete elimination of that posteromedial papillary muscle PVC. I'll ask our audience to pay attention here how we use the directionality and force sensing of the catheter, which help us to determine the contact with the papillary muscle. Of course, that led to complete elimination of that PVC after a bunch of lesions were given, and we were only left with this inferiorly directed PVC. One point to learn from that for myself was whether we should have ablated at the sharp potential or would have mapped at the early areas where far-field signals were seen, and catheter ablation should have been performed in those areas. Anyway, we got rid of that PVC and we moved on because we still had the inferiorly directed PVC, which was still becoming more frequent once we got rid of the superiorly directed one. As we can see here, now we are left with the right bundle branch, V5 transition, inferiorly directed PVC with positive negative lead one, which is suggestive of a PVC coming from anterolateral papillary muscle region. So we did the activation map as we always do. We have the Carto sound map with understanding of the anatomy, and we diligently map that anterolateral papillary muscle. This slide in the middle shows that anterolateral papillary muscle. And what was really surprising was the earliest site we found was in fact on both sides, septal and the lateral side of the anterolateral papillary muscle, almost suggestive that the origin might be deep intramural, with an exit on both sides of this papillary muscle. The septal side, we had this sharp signal, which was early, and the lateral side was also similarly early signals. Even after multiple mapping, we could not decide which one will be the better side because it was similarly looking signal, and therefore the decision was made to almost have a line around those two regions. Of course, limited ablations around the areas of early activation was done, and this ICE catheter does show the areas where we ablated with a force vector, and also we could look at the lesion as we deliver the lesions around this region. With this, we managed to ablate, we managed to get rid of, and as I'm really glad that audience all agreed, ablation of these papillary muscle cases, I think the best approach will be to use as many different technology things you have and use both activation and pace mapping to be able to try and eliminate these PVCs, which are challenging. No doubt activation map is the reliable method of mapping for most of these cases. However, the variable intramural depth of the origin of these PVCs and the variable exit may explain the controversies which exist in the utility of these pre-potentials and the Purkinje potentials seen during the activation map. So some cases we do see these fractionated early sharp signals, and other cases I'm unable to appreciate and we haven't seen those. Similarly, the evidence of variable exit or preferential exit, whenever we see, I think the pace mapping can help us to determine the best site of ablation. In this paper from Yamada and group, they found that the best site in these areas are where the best pace map is with a long stim to QRS or a latency. So when they found that if you have pace and you have a long stim to QRS before you have a perfect pace match, you might be at the site of origin rather than at the site of exit. I have few cases where I've used that and it seems to be really useful in those cases where you do see a variable exit. I'd like to conclude here, ladies and gentlemen. The ablation of papillary muscle PVC is safe and effective treatment strategy. Pre-procedural cardiac MRI and in vivo real-time ICE imaging can be helpful to assess substrate. Ablation remains challenging because origin can be located deep beneath the endocardium of the papillary muscle. These PVCs often exhibit multiple QRS morphologies due to preferential exits. So I want to thank everyone for their attention.
Thank you very much.